Politics of Madness, Anti-psychiatry Then and Now. Welcome back, it's Nathan again. So, after a few weeks of struggling with sleep anxiety and feeling overwhelmed, you seek help, but instead of being listened to, you're given a label, prescribed medication, and told this is simply how you are, possibly forever. Now imagine you couldn't refuse that help, couldn't leave, couldn't question the diagnosis. This tension between genuine care and institutional control sits at the heart of one of the most contentious movements in modern medicine, anti-psychiatry. To understand why this movement emerged, we need to examine what it was responding to. Anti-psychiatry emerged in the 1960s as a broad challenge to mainstream psychiatric theory and practice. It wasn't simply criticism, it fundamentally questioned whether mental illness existed as a medical disease, whether psychiatric diagnosis was scientific or social control, and whether asylums helped or harmed. The term itself was coined by David Cooper in 1967, though the ideas had been developing throughout the post-war period. But this wasn't the first time psychiatry had faced opposition. By the mid-20th century, psychiatric asylums had become vast warehouses for society's unwanted, overcrowded, under-resourced, frequently abusive. Treatments included lobotomies, over 50,000 performed in US mental hospitals between 1939 and 1951, insulin shock therapy, and involuntary detention with minimal legal recourse. Michel Foucault would later argue these institutions functioned primarily as mechanisms of social control rather than therapeutic spaces. Into this context stepped two figures who would define anti-psychiatry's challenge. Ronald David Laing was a Scottish psychiatrist trained in psychoanalysis, influenced by existentialism and Marxist social theory. His radical proposition, madness was not a medical pathology to be suppressed, but an intelligible human response to unbearable circumstances. He rejected the illness model entirely. For Laing, diagnoses like schizophrenia represented not disease, but a person's attempt to survive psychologically invasive families and oppressive social structures. Laing didn't just theorize, he experimented. In 1965, Laing established Kingsley Hall in London, a radical therapeutic community where conventional psychiatric hierarchy was abolished. No locked doors, no forced medication, no distinction between staff and residents. People experiencing psychosis were encouraged to live authentically, to work through their madness rather than have it suppressed. The community would provide support through the transformative journey. The reality proved rather more complicated. Kingsley Hall attracted drifters. Residents smeared feces on walls. At least 2 people jumped from the roof. The experiment descended into chaos, a cautionary tale about the gap between romantic theory and practical care. Yet Laing's influence extended far beyond this experiment. His best-selling books, The Divided Self, The Politics of Experience, brought psychiatric critique to mass audiences and the counterculture movement. Whilst Laing romanticized madness, another figure took a fundamentally different approach. Thomas Szasz, a Hungarian-American psychiatrist, argued something more provocative. Mental illness was a myth, not metaphorically, literally a conceptual error. His reasoning: illness requires physical pathology. The mind is not a bodily organ. Therefore, mental illness is an incoherent category, a metaphor mistaken for medical fact. What psychiatry labelled as disease was actually problems in living. This wasn't merely semantic pedantry. For Szasz, psychiatric diagnosis functioned as a license for coercion. If mental illness isn't real disease, then involuntary hospitalization isn't medical treatment, it's imprisonment without trial. Forced medication isn't therapy, it's assault. He saw psychiatry as a form of thought policing, using medical language to legitimize control over behavior that violated social norms but not criminal law. A tool for enforcing conformity disguised as healthcare. Szasz's critique gained credibility from disturbing realities. Soviet psychiatrists routinely diagnosed political dissidents with schizophrenia, confining them to psikhushka hospitals for the crime of opposing the state. This wasn't marginal abuse, it was systematic policy. Western observers asked uncomfortable questions. If psychiatric diagnosis could be weaponized so obviously there, what prevented subtler misuse here? Were rebellious youth or family conflicts being similarly pathologized in liberal democracies? The movement's critique thus operated on multiple levels. Theorists emphasized how language shapes reality. Terms like patient, treatment, mental hygiene weren't neutral descriptions. They were political choices that positioned psychiatry as authoritative medicine and positioned distressed people as passive recipients of expert intervention. Irving Goffman's asylums documented how psychiatric labeling became self-fulfilling, with institutions creating the very behaviors they claimed to treat. These critiques generated tangible changes. Partly influenced by anti-psychiatry, Western nations began closing large asylums from the 1960s onwards, a process called deinstitutionalisation. The vision: replace custodial institutions with community-based care that respected individual autonomy. Italy went furthest. Franco Bassaglia's reforms led to psychiatric hospital closures and the creation of community mental health centres, explicitly rejecting the medical model. But was this entirely positive? Deinstitutionalisation often meant defunding rather than genuine community alternatives. Former patients found themselves homeless, imprisoned, or simply lost in inadequately resourced community services. The rhetoric of liberation sometimes masked abandonment. This highlights a persistent tension. Valid critique of institutional psychiatry didn't automatically generate workable alternatives, which brings us to contemporary psychiatry's response. This highlights a persistent tension. Valid critique of institutional psychiatry didn't automatically generate workable alternatives, which brings us to contemporary psychiatry's response. Contemporary psychiatrists like Dr. Joe Pierre argue that anti-psychiatry now fights a straw man. Psychiatry has changed substantially. Involuntary detention is far rarer. Treatment integrates psychotherapy, lifestyle interventions, and medication, not medication alone. Understanding of neurobiological factors has deepened. The profession claims it already practices the self-criticism anti-psychiatry demanded, that reform happens continuously within the field, yet the movement's legacy persists in unexpected ways. Language has shifted. Clients often replaces patients, therapy replaces treatment. Advocacy organisations like Mind Champion Service, user rights and representation on mental health tribunals. Community care models, however imperfectly implemented, reflect anti-institutional philosophy. Crucially, interdisciplinary mental health teams now include professionals trained in social rather than medical models who may view psychiatric authority with skepticism. This creates ongoing tensions. Anti-psychiatry today is fragmented. Some continue evidence-based critique of over-medicalization, diagnostic reliability, and pharmaceutical industry influence. Others promote conspiracism, that psychiatry itself should be abolished, that all medication is harmful. Organizations like MAD in America occupy ambiguous space, amplifying lived experience and legitimate concerns, but sometimes platforming misinformation that may deter people from accessing beneficial treatment. We've traced anti-psychiatry from its 1960s emergence through its major figures, Laing's existential romanticism and Kingsley Hall experiment, Szasz's libertarian rejection of mental illness as a coherent category. We've seen how the movement challenged asylum systems, influenced deinstitutionalisation, reshaped professional language, and created space for service user advocacy. We've also acknowledged complications, chaotic experiments, unintended harms from policy changes, and the movement's contemporary fragmentation between legitimate critique and conspiratorial extremism, which leaves us with a provocative question. Did anti-psychiatry liberate people from oppressive systems, or did it liberate society from responsibility for its most vulnerable members? When we closed the asylums, were we respecting autonomy or abandoning duty of care? When we critique psychiatric authority, are we empowering service users or removing their access to expertise? When does justified skepticism towards institutional power become dangerous rejection of medical science? Perhaps anti-psychiatry's greatest legacy isn't its answers, but its insistence that we keep asking these questions.